Hello, I'm Dr. Stephen Gabarty. On behalf of CME Outfitters, thank you for joining us for the CMEO Snack series entitled Navigating the Mycophenolate REMS, an interactive approach for the interdisciplinary care team. This activity is supported by an educational grant from the Mycophenolate REMS Group, a consortium of more than 25 companies working to communicate and mitigate the risk of embryo-fetal toxicity associated with mycophenolate during pregnancy. This is the second of 3 CMEO snacks and will cover communication with patients about the risks associated with mycophenolate and pregnancy. Again, I'm Dr. Stephen Gabarty. I'm an abdominal organ transplant clinical specialist at Brigham Women's Hospital and an assistant professor of medicine at Harvard Medical School, both in Boston, Massachusetts. And I'm delighted today to be joined by Dr. Michael Wu, who is an assistant professor of medicine at Baylor College of Medicine. Welcome, Dr. Wu.
Thanks so much for the invite on such an important topic for both our patients and healthcare providers. I look forward to our discussion today.
Here is our learning objective for today's program. After participating in this activity, learners should be able to counsel patients of reproductive potential on pregnancy prevention and or planning during mycophenolate treatment, including contraceptive and alternative immunosuppressive therapies. So, Dr. Wu, if mycophenolate is problematic for reproductive health, what are the alternatives?
So I think the biggest question to start off with is that why did we prescribe mycophenolate in the beginning? So I think that's going to be specialty driven. I'm coming from a rheumatology background, so a lot of my discussion and with my patients are based off of indications of lupus and scleroderma, but certainly mycophenolate is used across the board in many specialties, including transplant medicine and et cetera. So I think it's the main sort of discussion for a provider to decide about alternative immunosuppression should be based off of what the indication is. So for me, to start off, we usually see this in lupus nephritis and scleroderma. And the biggest question then is how controlled is the disease? So is it early on in the disease process? Are we at the initial sort of start of lupus nephritis treatment? And how well is the underlying disease controlled? I think that really dictates how the pregnancy may evolve over time or the risks to the mother and the negative impacts during the pregnancy. And finally, timing is important. So again, the timing of when you stop mycophenolate and when you should consider contraception. So for me, timing is stopping 6 weeks or at least 6 weeks after mycophenolate is stopped, that conception could theoretically be considered. I know in transplant medicine, I think in rheumatology, we often wait a little longer on alternative immunosuppressants just to see if the underlying disease is controlled. So typically 6 months to a year is sort of my guideline in switching over to another alternative. I wonder in transplant medicine, is it the same or are there other considerations to take into account?
It's definitely very similar. We generally wait a year following organ transplant before we have this discussion with a family planning perspective. So definitely similar timing.
Absolutely. And I think once once we decide sort of, again, is it an appropriate time? I also think it's important to talk with the patient and see what their goals are and if they're willing to wait a year. Again, I think for transplant, there's different sort of considerations to take into account. But for milder lupus indications, certainly we could consider switching to an alternative and considering sort of pregnancy earlier than that year mark. But again, the acuity, the indication, how sick the patient is, I think all play into account and when we decide an alternative is appropriate. So a couple things to consider. So again, from a rheumatology perspective, there's a great sort of resource that I use in my practice. It's the 2020 American College of Rheumatology Guidelines for Management of Reproductive Health. And the caveat is it's in rheumatic and musculoskeletal disease. So a lot of the immunosuppression we're going through is typically used in rheumatic sort of indications. So certainly there are a lot of other new immunosuppressive biologic medications that are out there that have other sort of indications in IBS and transplant. IBD in transplant. So first off, I like to present the first slide. So alternative for male patients, it's pretty simple. We avoid two medications, typically cyclophosphamide and thalidomide. Other than that, most of our immunosuppression, including mycophenolate mofetil and mycophenolic acid, are both conditionally recommended to continue. Any sort of differences in the transplant sort of literature with male patients?
No, it's pretty similar. There's been some discussion about the potential impact that mycophenolate might have on males looking to father children, but to my knowledge, there's no data that can confirm that it's any problem. So we certainly allow our male patients to remain on mycophenolate while they're trying to have children.
Absolutely. And there's also one more immunosuppressant we point out more from sort of studying for rheumatology boards, but sulfasalazine, not often used in the indications that could be an alternative for mycophenolate, but in men can reduce semen count. So that's a sort of an interesting sort of caveat for sulfasalazine if that's considered for other indications and other specialties. So I think the main discussion is alternative for our female patients. And I think there are a couple sort of intricacies, or I'd say additional sort of factors that we need to consider in patients that are female who are looking for contraception. Is there different times that we have to worry? So preconception, post-conception, or during pregnancy, and then also post-pregnancy with breastfeeding. And again, the ACR guideline for management of reproductive health has a great sort of diagram of, again, rheumatology-specific immunosuppression that I think are helpful in, again, providers who are prescribing potential alternatives to mycophenolate. So if you look at the chart, a lot of the medications that you see are, again, lupus-driven, also for biologics with RA. But with the ones that I like to point out, azathioprine is a very common alternative that we use in our lupus patients, in our ILD patients also, as a safe alternative in women who are considering a pregnancy. And you can see again on the chart that it's safe pre-conception, during pregnancy, and after conception. Other caveat or other immunosuppressions, I like to point out prednisone. We usually like to use less than 20, but that's not an absolute. If a patient's flaring with lupus nephritis, we certainly do use higher doses of steroids. I imagine with transplant, that's the same case. If you have to use higher, you have to, but ideally we like to try to stay under 20, but the prednisone, again, is a safe alternative if you have to go higher. So avoidance, so immunosuppressants to avoid, we really try to avoid, these are sort of our red box medications, methotrexate, leflunomide, and of course, the sort of topic of our discussion, mycophenolate. Again, what I like to point out in this sort of box is that it says stop greater than 6 weeks, but it also has a caveat of assessing disease activity or stability. I think that's super important. I think as providers and as for our patients, we have to discuss sort of the safety of their underlying disease by switching to another immunosuppressant. And again, having that open discussion about, while we can get pregnant at more than 6 weeks after stopping, we should probably wait longer to, again, ensure that the mother and the baby can have a healthy and normal pregnancy. Any questions about sort of alternatives or that you have?
Yeah, Dr. Wu, one thing for us, I know that we've tried to stay away from mTOR inhibitors. They're very potent anti-proliferatives, have shown some malformation in fetus in animal studies, but certainly not studied further enough along in adults. So that's one difference here. But I want to get your opinion on azathioprine and then a second opinion about one of our transplant drugs, and maybe I can give my opinion when we get there. But azathioprine has long been understood as a drug that has the potential to cause fetal issues, whether it's a rare instance of malformation, but also preterm birth. Just curious as to why we see this as our generally considered safest alternative to mycophenolate in these different immunosuppressed populations.
I think if you look back at the studies, a lot of the times azathioprine, the dosing is important. So I think it's dose dependent. In rheumatology, we try to stay at a 2 milligram per kilogram dosage, but certainly higher doses, I think, have higher potentials of teratogenic effects. The low preterm birth weights, I think, also could be related to underlying disease activity, whether that's renal transplant or lupus. You can certainly imagine if their underlying disease is not well controlled, because we might have changed to an alternative immunosuppressant, that could lead to some of those sort of, I guess, negative pregnancy outcomes, like with low birth weights. I think I want to stress, though, is underlying control of disease is super important.
Certainly.
Even if alternatives have all their certain small risks, I think if you look at hydroxychloroquine, there's some sort of data in human, so again, dose-dependent data showing that there could be some retinal toxicity in children. But again, I think a lot of it is dose-dependent and understanding sort of the clearance mechanisms in certain drugs. So for hydroxychloroquine, again, there's new studies that show lower doses are sometimes safer, again, renally excreted. So reducing the dose dependent on sort of renal sort of function is important also.
Certainly. And I had mentioned the mTOR inhibitors, certainly in a group of drugs that we use somewhat frequently in the organ transplant population, but a drug that I use in increasing frequency is belatacept, obviously not containing a rheumatologic indication, but very similar to abatacept that was listed as a drug without enough information to truly tell whether or not you can have a successful pregnancy with it. I know in the transplant population, there have been 2 or 3 case reports of successful pregnancy in patients on belatacept that just couldn't be converted off, but still not enough information to truly keep it as an agent if there are alternatives for your patients as well. So just an aside for our transplant practitioners.
Absolutely. I think a lot of the newer biologics, like you said, we just don't have the data for. And for a lot of the newer biologics that we use, the injectables, abatacept, in men, certainly we don't have enough data. In women, I think there's some data that we can continue until contraception. So it's still those sort of different phases of pregnancy or again, contraception for a female patient we need to consider before conception, during pregnancy. Of course, we stop if we don't have enough information. And then again, post for breastfeeding, when is the time to really restart medications? Any consideration of for belatacept when you guys restart for breastfeeding? I don't know if there's enough data for that, but
again, not enough data, but being such a large molecule, it's something that we've considered to be able to restart relatively shortly, but I haven't had enough experience, maybe one patient that has fit that bill.
Absolutely. And again, I think a lot of the discussion that we are having also should be held with the patient. A lot of the times we talk about alternatives and we're talking about providers sort of guiding the discussion, but I also think that there's a lot of gray in rheumatology, a lot of gray in sort of the discussion about alternatives. So having that frank discussion with the patient is really important. So I guess it naturally leads into who should we counsel for all of these decision-making and shared goals and decision-making sort of discussions. And so who's at risk? I think it's important to note that it's mainly female patients after puberty, female patients who have a uterus and ovaries that are not through menopause yet, and again, who are having intercourse with a male partner. And so that's sort of the population we really should target. Certain education things that we always need to discuss with our patient is just talking about birth control. I think for me, the biggest thing is reinforcing it every time we discuss in a follow-up. So we typically see our patients every 3 months, and I always find it very imperative for this population that I just spoke of, that we discuss their reproductive health and their goals at every visit. So what type of birth control they're using, if their goals have changed. A lot of the times I ask sort of, do you have plans for pregnancy and when is your timeline? Is it in 1 year? Is it 5 years? And really trying to guide our management towards their certain goals. Any sort of pearls from your practice?
I think that covers or should cover everyone's practice when you have a female that's looking to start the family planning process. You know, you hate to intrude on something so personal, but obviously the healthcare team needs to be involved in these decisions, and also in the planning process to make sure you do it as safely as possible. And it should be something that's addressed on a relatively frequent basis with your patients that express an interest in conceiving. Absolutely.
I think birth control, it's a sort of tricky discussion. Again, timing, sometimes we have limited time to discuss sort of birth control. So utilizing our gynecology colleagues is super helpful in helping us prescribe birth control for our patients. But I do think it's important that we talk about sort of the options or the recommendations while you're on mycophenolate. And I think when I was in training and fellowship, I wasn't aware that there is a sort of different sort of birth control recommendations while on mycophenolate, whether that's, again, one method or two methods. And so option one is just one method alone, but that's usually a patient with an IUD, tubal sterilization, or their partner has a vasectomy. What I think is important for all providers to know is that if a patient's on a hormonal-based sort of oral contraception, that second barrier sort of birth control is recommended. I think in an ideal setting, we counsel our patients, we talk about birth control, we get them to, again, avoid pregnancy as best as we can. But there's always those circumstances when you do get a sort of a pregnancy test and the patient contacts you and they say, hey, I'm pregnant and I'm on mycophenolate, what should I do? I think it's important for providers who do give mycophenolate to understand the other sort of options that we have. And I think emergency contraception is something that we can, again, utilize our gynecology colleagues, but also be educated on the different sort of formulations that we have. Certainly there's oral sort of plan B emergency contraception that is out there. I think there's one that's a prescription and one that is an over the counter. And again, needs to be given within 3 to 5 days of unprotected intercourse. And again, using our gynecology colleagues, IUDs can also be used as emergency contraception. But again, these are options that we should be knowledgeable about and hopefully can help our patients make a decision about if they do get pregnant, what sort of direction they want to go in.
Thank you so much, Dr. Wu, for a very important discussion on mycophenolate and its REMS program. Now, by way of summary, I'd like to offer a few SMART goals to our audience, which are specific, measurable, attainable, relevant, and timely. For appropriate patients of childbearing potential, it's imperative for us to identify a suitable alternative to mycophenolate, regardless of the indication of why they're using the product. You have to have direct discussions with patients about risks to the fetus with mycophenolate use. And it's so important to counsel your patients on pregnancy planning, family planning, and the need for effective contraception while they're being treated with mycophenolate. As you know, this is the second of 3 CMEO snacks on the mycophenolate REMS. Please visit the virtual education hub at www.cmeoutfitters.com to participate in parts 1 and 3. And don't forget to complete the evaluation to claim credit for today's activity. Thank you.